this on? Yeah, okay. Wonderful. Oh yeah, sorry. Yeah.
So hello everyone. It is my pleasure to introduce you our next speaker, Dr. Sven Mensing. He is currently the head of Pharmacometrics at Abbvie. He holds a PhD in medical informatics from the University of Heidelberg and a master's degree in biomathematics from the University of Greifswald, Germany. Sven joined Abbvie in 2008 using mechanistic mathematical models and advanced statistical tools. His team delivers data-driven assessment to optimize Abbvie's clinical development strategies for speed, size, and insight. He was named Senior Research Fellow in 2023. And welcome, Dr.
Thank you so much. When I was invited to join this symposium and give a talk, I was wondering what I could talk about. That would be something like a tutorial, but also related to working in the industry. And something on my desk at that moment was pragmatism in the end. So we have spent a lot of work in scripting, automating our reporting tools, that we can have reports generated very quickly, because in the industry you have to have very rapid turnaround times. So the data is available and 2 minutes later you should be done with your work, ideally. We have a few days or weeks of work, but still for a full PKPD report, which has 100, 200 pages and an appendix and e-data and things associated with it, forces you to be really conscious in what you do with your modeling. And currently we went into a direction where we do a lot of logistic regressions, simple hazard models in our reports and submit those. And I have found that the discussion in our company, at least, should also be a bit more in the direction of, can we do a bit more advanced modeling again, which we did earlier without the time pressures. And this is some collections of thoughts I had around this, which I bring here. So this is a mixture of a tutorial, some thoughts from my end, maybe a starter for a discussion, and yeah, we'll see how this goes. Like I said, I'm an Abbvie employee and shareholder. This may not be my company's views. And one slide I usually like to show whenever I'm presenting to a broader audience is, why do we do pharmacometrics? And the thing is, the classical analysis gives you this p-value, which is that you have a likelihood of less than 5% that your data comes from a drug doing nothing. This is what a simple statistical analysis will give you. And of course, this is not the answers we're looking for in clinical development programs. And these are also not the answers FDA is looking for. So there's been a big discussion on Project Optimus over the last years, which is FDA is saying, you cannot just dose people up to the highest dose possible anymore. And this is your dose for phase 3, more or less. You have to be more rigorous in developing your drugs. You have to have a good description. What is the optimal dose? Sometimes less is more. And there's actually a nice Seinfeld stand-up on this on YouTube. If you look for Seinfeld and maximum human dose, I didn't dare to show it here for copyright reasons. So, but it's a quite funny 1-minute bit on that. And oncology is different. And if you're looking at non-oncology phase studies, you have the luxury of having a phase 1 study with healthy volunteers that gives you a lot of information on your pharmacokinetics, on your initial safety analyses. Then you go to a proof of concept study with multiple doses, to a phase 2b, where you're finding the optimal dose, which has 2 or even more doses, which gives you the opportunity to go to phase 3 with 1 dose, maybe an additional dose to just show your dose is actually right. So this is a nice process where you have a good characterization of your dose. In oncology, in the pre-Optimus phase, you went up to this maximum tolerated dose because you wanted to treat patients with the best dose as fast as possible. And this was, especially in the pre-immuno-oncology phase, the maximum tolerated dose, so that patients can get the best benefit with manageable safety profiles. This usually led to you having only 1-2 doses being fully explored, being in a registrational trial. And this is not what we want anymore today. This is also not a new topic, so there have been research on this for several years now, but it gained a lot of traction over recent years with FDA having, like say, Project Optimus, that dose finding and optimization should be a paradigm across oncology that emphasizes optimal dose finding, that is not focusing on efficacy only, but safety is now also a focus of these initiatives because we have well-working drugs, so we can also afford now to look a bit closer on safety. The issues are that you have this inadequate characterization of your dose. So you have to work on that. The highest dose being used as the default. And yeah, I more or less said this already, that you should not do these things. And one example I found while just browsing the internet was, what is this even? Niraparib. And they did a follow-up study where they, can we see that? Okay, so the orange one is the 300 milligram starting dose. So everybody had a starting dose of 300 in that trial. And they did a post-phase 3 safety analysis, and they have found out that after several months of treatment, only 25% of the people actually remained in the starting dose. And this is something that shows you that there may be room for improvement with those doses. And in an updated label, they now have 200 as a starting dose for patients meeting certain characteristics. So these things are getting optimized over the time. And these are the key takeaways for Project Optimus, that a robust dose selection is necessary. Dose optimization post-marketing will not be acceptable anymore with the FDA, so they are very stringent on that. You have to have randomized dose expansion studies looking at multiple doses to show to the FDA that you have found the optimal dosing to your drugs. And in order to do so, you need to look at PK, PD, PK/PD, so the things why we are here. And this is more or less the introduction or the motivation to my talk. Model-informed drug development, I don't think I have to spend too much time on that. But for me, as a pharmacometrician, this is the way to go. You take the data that is there, some preclinical data, maybe even some assumptions. You put it into a model as good as you can. You simulate the outcome or the next study, which you're looking at, in order to gain the most insight, to get better data, to make your model better, to run a better study as an iterative process, getting you to where you want to be, which is getting a good drug to the patient at the right dose, ensuring efficacy and safety. One thing I noticed during my career is that people are a bit stumbling on that models change over time. So this is something I heard multiple times. So we talked about communication earlier. So this is also something I learned to communicate to people, that we start with a model, especially when you talk about QSP, mechanistic type of models, where you have a lot of assumptions in biology. And over the time, you will get more and more data. And your focus goes more and more into the direction of making decisions. And over this course of time, your models will change. And the things you can do with those models will also change. And this is something, like I said, which I found very peculiar. That people were asking me, well, your model changed every year. Why can't you just, yeah. So this is something in terms of communication that you say, this is the current status we have. If we get more data, if we get more information, things may change, and be aware of that. Yes. Short recap, pharmacokinetic differences. So we have different drugs that have different profiles. So you have the the small molecules with a 2-compartment model. You have large molecules, usually also 2-compartment model, except TMDD is visible at the lower doses. CAR-T has a different profile. And one thing that Abbvie is very involved in is ADCs. And there we actually did a small, colleagues of mine did a small analysis where we had one ADC, and we looked at whether our complex model, where you have the ADC having the toxins still associated with it, that is being deconjugated to a normal antibody and releasing free toxin on the way, and having those peripheral compartments as well. And those conjugates can have different levels, of course. So you can have an ADC that has 2 toxins associated with it, 4, 6, up to 12, I have seen. So these models can become very complicated, convoluted. And we were looking at whether we can also describe this with 3 separate models. So just describing the conjugate as a 2-compartment model, the antibody, and the toxin as well. And the outcome of that is that, yes, you can do that. We have published on that. So the VPCs and the goodness of fit plots look very similar. One thing for consideration, though, with working with simplified reduced models is that you need to have enough information. In some cases, the ADC may be working with a toxin that is very, very potent. We had bought a company called Stemcentrx 10 years ago, and they had a very potent toxin which was barely measurable. And most of the concentrations were below the limit of detection. So we had to rely on the complex model so the ADC could inform the toxin concentrations as well. Another thing regarding communication and discussions in the team is also because the ADC is releasing the toxin, the PK profile will be pretty similar to the ADC profile. So you will end up with a small molecule that has a half-life of several days. And this is something that is causing disconnect in the understanding of the medical team. They would say, this is a molecule that has a 6-hour half-life, and you're telling me it has a 10-hour half-life in your NCA analysis. But this is because the ADC is somewhat an extended release formulation to an extent. So there also the complex models might help, where you could input the clearance of the small molecule as being in hours, and then the rest of the model taking care for the dynamics, explaining why your toxin has an NCA half-life of several days, actually. And yeah, of course, those models may be a bit better with sparse sampling. If you only have trough samples, this may help you avoiding some flip-flop kinetics in your modeling. So this will be the theme of the talk, that you can do things with a more simple approach, but there are certain drawbacks which you should be aware of, which you should be communicating to the team, and just being aware of that you may have biases in these analyses. I'm not sure if this is the right audience for that. So you have exposure response, and what I just wanted to point out here is you have those simple models, and you can go up to the very complex models. And especially in the industry, this is also a matter of resources. And one big resource is time. So if the decision is to be made 2 days after the data is available, you will not have the time to build a complex QSP model, calibrate all the parameters to what you see in the clinic. You will have to go with an empirical model, maybe even just a logistic regression. But then maybe thereafter you have the time to do things. So this is always a balance to work with. And I think we also had it in the panel discussion. If you want to be influencing a decision, you have to be there in time. So there's this trade-off between what you can do with your models. Because we all know that longitudinal data, accounting for dose information, concentration information, and effect measurements over time, has a lot of potential to explain what your drug is doing and how it is reacting, how the drug is influencing the body. If you just do an endpoint analysis, where you only look at the week 24 data, you lose a lot of information, a lot of insight, and you may be introducing bias to your analyses. Yeah, similar example in the same direction. This was an analysis that was brought to us where the team said, well, there's nothing happening with this biomarker. If you look very closely at the axis, you see that the change in biomarker is actually at 250% or so at average. So something is happening, and the solution to that was to look at it over time. So this is an example where a simple analysis did not give you the results you wanted, but a more complex analysis, I mean, it's still just an indirect response model. Nonetheless, this helped us greatly to describe the data that is available and to make predictions for subsequent analyses. So again, simple analyses may work. There are cases where they don't. And yes, so recently there was a nice publication from our colleagues at Metrum that looked at exposure response metrics. So if you do a logistic regression, you have to pick an exposure to relate your endpoint to. So if you look at something like neutropenia, thrombocytopenia, you will have a yes/no. So a patient will have this side effect, or the patient will not have this side effect. Then you would relate this via a logistic regression, simple regression model, to an exposure. So one exposure could be the AUC in cycle 1. But a very common approach is to take the exposure like the average concentration up to the event. And this comes to my earlier remark that you have those oncology studies where patients don't stay on the same dose. So this may work in immunology where everybody gets the same dose throughout. But in oncology, there's a lot of adaptation. If patients go to a life-threatening condition with their thrombocytes, there will be a dose holiday, there will be a dose reduction. So you have to do something that accounts for those interventions as well. And one idea that was used, or is still used, is this average concentration up to the event. But as shown in this paper, there is a drawback that you have some biases with that. And motivated by this example, we took it a step forward and simulated a two-compartment model, plugged it into a Freeburg type of platelet model, or neutrophils, I think I call it. Doesn't matter, it's just an example. And we simulated neutrophils that are being killed by a drug. So we have two drug effects, one of the progenitor cells and one on the circulating cells. And we just simulated what would happen with this platelet model. And then we calculated the C average. So this is just the integral of the concentration until the event, divided by the time of the event. And I will actually not show the logistic regression part. So this is something we may be showing a page later this year. And what we have here is now on top, you have the concentration. So daily dosing interval of a drug. You then have the neutrophils going down because the drug is harmful. You have the C average, which is jumping around a bit at the beginning, but then it would stabilize after a few doses. And what you see then in the lower part is we have the incidence of neutropenia. So up there, looking when you cross the threshold, this is the time of your neutropenia. And then we look at the concentration that happened until then, and you see that, sorry, online people, that there's a nice exposure-response relationship. So with lower, if you are in the lower quartile of the exposure, you have less incidence, and if you are in the higher quartile, you have a higher incidence. And the relationship becomes even clearer if you look at the C average at steady state. So this is just the dose divided by the clearance and scaled for time. The opposite extreme situation is if you have only one dose. Unlikely in oncology, of course, but for illustration purposes, you see that the concentration goes up and down very sharply. The neutrophils go down and come up again. Your C average will go up and then go down over time. And you see that all the events happen at the beginning of the dosing. Because this is the time here when the neutrophils are the lowest, is when the concentration is the highest. And then people that will not have an effect will be included in the model as not having an effect. But those people will then have a very low C average concentration back here in the end. When you're looking at the C average over steady state, so where you don't account for the time of the event happening, you see a more or less flat exposure-response relationship, what is more or less what we would expect because all the patients were giving the same dose. Okay, these were the two extreme cases. In oncology, you can also have a ramp-up dosing. So in immuno-oncology, you can have a priming dose. I don't even know the other names. And then you have the maintenance dose. And this is another situation where such a simple analysis can fool you. Because you have an increase in your concentration in a stepwise manner. And if the event is already happening here in the earlier phases for a lot of the subjects, and for some subjects it's not happening, those subjects will receive the higher dose, but they will not have had an event. So subjects that are more susceptible to the treatment will have an event with the early lower concentrations than subjects that will not experience an event at all, receiving the higher C average concentration. In this case, you would have an inverse relationship. Though the model is very straightforward, higher concentration gives you higher neutrophil effect. But just by the way you are summarizing the data here with average concentration up to the event can give you a biased relationship. Well, if you look at things like C average steady state dose, this is steady state dose over clearance will give you a much nicer relationship. So I think this is a very important topic that those simplified analyses can lead you down a way that you don't want to go and give you wrong results or wrong conclusions. So if doing these analyses, at least look at several exposure matrices like AUC cycle 1, AUC up to the event, AUC steady state, to see if this picture is matching or if there's something wrong that you should be taken care for. And maybe you have to consider a more complex model to work with this data nicely. What way is time? Yeah, and those complex models, of course, have other advantages. So here, this was a question where we were asked whether we want to do a ramp up in a bi-weekly or weekly fashion. Will this give us patients that are more at risk, less at risk, and so on? And here we could show that in this case, yes, people with a weekly ramp up, of course, have lower levels of this certain endpoint. But after a few weeks, they would be ending up at the same level. And if they are at their stable dose, they would also be at the same level, so that nobody up front was lower than they were at the end. So this is something where you can then justify that your ramp-up dosing may be okay to be a bit more aggressive if you can show these kind of things to the regulatory agencies. Yeah, I think we heard something about precision dosing as well. So these models, of course, have also the advantages that you can, with some smart Bayesian analyses, which a colleague of mine, Corinna Meyer, did during her PhD. You can enter the data and then predict if you change the dose for the next dose. You can then predict if a patient would have neutropenia, grade 1, 2, 3, and then you can level out what you want to have. In this case, grade 3 was actually something they were looking for because this was also associated with efficacy. So in this case, one would have gone with the standard dose or -15 dose because you don't want to have grade 4, but you want to have grade 3 as this is associated with efficacy. So those models are also able to help you with those more complex decisions. So they have their merits. Yeah, another, and my last example is something I did several years ago, but I have not seen in a while, is time to event modeling with a changing hazard function. So this is something that came back on my desk and that I wanted to just share with you as an example as well, because I think it's a very illustrative example. And in a time to event analysis, you are plotting the percentage of people still living in a trial. And this is a monotonous declining function. So you have to have that the survival function is less if the time is, over time, the function has to go down and not stay flat, or not increase again. And this is done by having this cumulative hazard. So this lambda here is a hazard based on certain covariates that is integrated over time. And these models, this lambda is not something that has to be constant over time, but it can also include a certain drug effect. And this is something you can do in your PKPD modeling, build a time to event model that includes this drug effect. And this is something where we had, this is just the standard of care arm, which I can show here. And if you use a model that is not accounting for dose treatment, you will have a very bad fit, actually. And this is then something we noticed, what is different in this standard of care arm. And the answer is people were getting chemotherapy with 3-week cycles or 6 cycles only. And also some people were skipping a dose. Dosing was stopped. So when taking into consideration these kind of things, you get a better fit. And this is something we had. So we had this hazard being a baseline hazard multiplied by the efficacy of the chemotherapy. And the chemotherapy was 1 if there was no chemo being given. And it was just an estimated theta during the time the chemo was active. So we had a 3-cycle chemotherapy. So for reasons I don't recall anymore, we assumed the chemotherapy is acting for 20 days, not 21. And when doing that, you get a simulated hazard function that goes down at a certain rate. And then in the gray areas, the chemo is not active anymore. So you had a chemo dose here. Then 20 days later, the chemo was not acting anymore. And here it's a bit even better to see that the chemo is slowing down the drop in the hazard function. And then once the chemo is not present anymore, you see a sharper decline of the hazard function. So the chemo is actually reducing the rate of death in the patients. And when you account for that, You have your last chemo dose at week 15 plus 3 weeks, it's working. You see nicely here that the slope of the survival curve is less steep here. Then it starts to get steeper, and the data is way better described. So here again, a more complex model, thinking a bit about the data and what is causing this data can get you to a better model that is helping you describe the data better and making better decisions. And in the end, this is just the start. So this is a figure I also always like to show that what we as a pharmaceutical company or as a doctor can decide is which patient gets which drug therapy. And everything else is just a function from that. So this is coming back to my earlier screen where we can say this patient is getting this drug and everything else is derived from that. And it's not only PK or biomarkers or the effect. There's also a placebo effect to be taken into consideration. There are side effects taken into consideration. These effects in the patients are then translated into a clinical endpoint. So sometimes you just have a survey or a score, a physician assessment. In case of Alzheimer's disease and others, you have disease progression to take into consideration. The effect may cause dropout. So people that don't see a response may not be willing to take the drug anymore. Or in case of pain medication, it's actually the other way around. We had this, a pain medication was working so well that people stopped taking the pain medication, which is also not good. Or another thing was, this was post-knee surgery pain medication. People were feeling so well, they went on a hike again, but the knee was still damaged. So yes, and on the other hand, you also have side effects. If people don't tolerate the drug, you will also have dropout, which will then, in the end, affect your efficacy or your readout because people are not counted as responders if they are dropouts. Yes, all of this is affecting compliance. And then you have other things more for the pharmaceutical industry, but you have the market value of your drug being driven by the side effects, and so on. You have competitors, generics, which are also adding to the mix. You have covariates affecting all of these things in your model. And you have things like backup compounds and new treatments options that emerge. And what I always find impressive is that one thing we can impact is who's getting which drug, and everything else is just a function of that. And the complexity of these functions is determining how good your development program will be. So in conclusions, complex modeling may require more resources, but sometimes it's really worthwhile to do that. Simple models are easy to handle, easy to implement, easy to automate, but they may have their challenges on their own. And this is something we need good modelers for, to know what they're doing, to know which biases we're introducing, how to handle that. So in order to have a good pharmacometrics group, a good development program, ask the right questions, see that you have the data you need, get the resources and talent you want for that, watch out for the timeline, and then you can decide on the appropriate complexity of your modeling to make this a successful exercise. Thank you very much.
We have time for one question.
Thank you. I agree with everything that you said, but I do have one question that I've never been able to address. So you do have the scenario frequently where you get the protocol results and the timeline says that you will finalize the protocol for the next study 2 days later.
You will
finalize the protocol for the next study 2 days later. And that protocol will go to the FDA and to everyone, to the sites.
Protocol or the report? So the
protocol, the next protocol, the study, the protocol for the next study. Sorry.
Yes. Yes. No.
And you propose, you do some preliminary analysis, and then you wait for later for the real analysis.
Yep.
But if the real analysis changes, you get a report. The report has to go to the FDA. It has to go internally, and that's a real problem.
Yes, it is.
And I've often thought that, you know, if you're going to do that preliminary result, then you just stick with that and you defend it, because if you get a different answer, then there's going to be questions, including legal questions, liability questions, if you chose the dose wrong.
True. Yes, you're right. So one thing we do is that we have early unblinding, so that we don't have to get the data one day before everything has to go out, but we have a process where we get the data 8 weeks in advance. We can spend some time on setting up the analysis right, doing some early data checkings. Like I said, we spend a lot of time on scripting our analyses so that we can work with preliminary data have all the scripts ready. Once the final data is there, just click on a button and you have the updated report. Yeah, I know. I'm talking to professionals here, but this is the marketing we have. Yeah. And but there's still the risk that you work with preliminary data, with early reads. You're running a risk. I mean, this is a risk the company is taking, and you have to do your best to put in your best. But there will still always be a risk remaining, and then you have to have a discussion when the final phase 3 data is there. And of course, you don't forfeit data, but you work with what you have and be open and transparent about that.
Okay, thank you, Dr. Mensing.